The term patient and family centered care actually has been around for over 50 years. So it's not a new term. I think what we're seeing is a couple of things. First of all, there's an increased emphasis on patient and family's experiences as they go through care. And an emphasis from the government side, from the CMS side, in which now we're measuring care experiences using tools like HCAHPS for hospitals. And it's raised the awareness of the importance of looking at care through the eyes of patients and measuring their experiences. The other side of that is that PFCC's sort of been a touchy-feely kind of concept and means different things to different people. And I think now we're at the point where we can actually apply science to patient and family centered care, which maybe we didn't have before. So now you're seeing the interest from the provider side and looking at experiences, but also we have tools to both measure care experiences and also improve care experiences. And when we talk to patients and families, the important thing to me is that when we talk about experiences, it forces everyone in healthcare to have a broader definition of care. Meaning, as a physician and a surgeon, many times focus has been on what happens in my office and what happens in the hospital. But when you talk to a patient about their experience, it's a full cycle of care that starts at their home and makes an appointment and comes in for their office visits and gets their testing and yes, goes to the hospital, but has to go home and do rehab and exercise, has to deal with insurance companies, has to deal with multiple silos that many times we don't deal with. So this requires us to really look at an experience as defined by a full cycle of care, which, as you know, is a very important emphasis in the new care delivery model. The number one requirement for the PFCC methodology in practice is to require all caregivers to view care through the eyes of patients and families. And the most powerful tool that we have in our toolbox is shadowing. And shadowing has an observer, a shadower, that is attached to the patient and family as they go through their care experience. So they actually become part of the family unit. And they're there to, it's a very open process. It's not a secret shopper kind of thing. Everyone on the caregiver side knows it's happening. But what we do in that process is we have eyes and ears to not only capture objective information, but subjective information from the patient and the family as they go through their experience. The earlier you have that viewpoint that we are taking care of patients and families and we have to view their experience as the utmost priority, the better caregiver you will be. In many ways, the most uninformed, healthcare uninformed person is the best shadower because they have no preconceptions. And one of the requirements that we have for shadowers is not only to collect information, but to offer solutions. And some of the best solutions come from people that are thinking differently.